Emergency Medicine channel. Shall we start? A 56-year-old male patient came to ER with complaints of fever associated with chills since last 3 days and oral ulcers and difficulty swallowing since last 2 days. On initial 10-second assessment, airway was treated, no pooling of secretions, no blowing of sounds, breathing, respiratory rate 12 rate per minute, SpO2 97 on room air, circulation BP was 149 km/h, heart rate 85 beats per minute, disability GCS was E4V5 GRBS 154 mg. Exposure, patient was fed bed 100 degree Fahrenheit. Adjuvants to primary survey, we took a CBC CRP, total count was 500, granulocyte percentage was 40, HB was 11.3, platelet 46,000, CRP was more than 230.
What is your inference from that?
There is neutropenia, granulocyte was 40, so ANC was around 360. So it was according to grading of neutropenia. Mild is 1000 to 1500, moderate is 500 to 1000 ANC count. Severe is less than 500, profound is less than 100. Here it is a severe neutropenia. Coming to VPG, pH was 7.984, sodium was 136, potassium 3.5, bicarb 24, lactate 2, and creat 1.03. There was no acidosis or
Hemoglobin?
HB was 11.3.
Lactate?
1.03.
2.
Or 2.
What is your opinion? Is it normal or
No,
near normal?
near normal. Coming to sample history, patient is a known case of rheumatoid arthritis and COPD on tab hydroxychloroquine 200 mg, tab leflunomide 20 mg, tab methotrexate 10 mg weekly lunch.
What are the side effects of all these drugs? Hydroxychloroquine, leflunomide, methotrexate.
Hepatotoxicity.
You take leflunomide, hepatotoxicity is there. Skin
Pulmonary
rashes,
skin rash, GI symptoms, nausea, diarrhea, vomiting.
hydroxychloroquine.
Hepatotoxicity,
Okay.
pulmonary fibrosis.
Most important is what? Eye, retinal changes, pigmentation, black pigmentation. Third one is methotrexate. What are the side effects?
Hepatotoxicity, pulmonary toxicity, GI symptoms.
Toxicity means what?
Liver cirrhosis,
Liver
fibrosis, pulmonary
and
fibrosis,
fibrosis.
GI symptoms, diarrhea, vomiting, bone marrow,
Bone
marrow
marrow
suppression.
Most important among all these things is bone marrow suppression. To prevent that, we are giving something. What is that?
Folic acid.
Folic acid.
The patient was on tab Folvite 5 mg only, and also since the patient was COPD, was on metered dose inhaler of salbutamol aspirin. Patient presented to ER with complaints of fever associated with chills since last 3 days, and also has complaints of throat pain and ulcer over the oral cavity, difficulty swallowing saliva, liquid and solid since last 2 days. Patient had history of intake of methotrexate 10 mg per oral tablet 3 consecutive days. Actually, according to his dosage, it was once in week. So
what is the dose of methotrexate she is
10 mg weekly
30
once
mg he has
taken, and he has a non-compliance for folic acid since last 1 month. No history of nausea, vomiting, diarrhea,
What is
abdomen.
the advice of maximum how much dose he can take in rheumatoid arthritis?
12.
25 milligram up to 25 milligram is acceptable in rheumatoid arthritis itself. So alone that 30 milligram may not produce bone marrow suppression. There may be something else, including folic acid. She might not have taken some other viral infection. We don't know.
So there was no history of nausea, vomiting, diarrhea, abdominal pain, any bleeding manifestations like gum bleeding, nose bleeding, or no renal function reduced during output. Or patient had initially been to outside hospital. Initial investigation in outside showed a patient has leukopenia, total count was 1000, thrombocytopenia 68,000, and elevated liver enzymes. OTPT was 223 and 228. They have checked serum methotrexate level and it was less than
Is
0.
it increased recently or previously?
It increased recently. He has no, it's not a known case of severity or any other disease. Outside, they have already given injection folinic acid 15 mg TID was given along with injection GCSF 300 sub-Q was given from outside and was referred for further management to AIMS. On arrival here, we checked our CBC CRP and patient was having total count of 500 and ANC of around 300. So and CRP was more than 230. So suspecting neutropenic sepsis.
Why sepsis?
Patient having fever.
Fever is not sepsis.
CRP more than.
That doesn't mean that sepsis. What is telling you that patient is in sepsis? What organ dysfunction? Fever. That means sepsis. What do you mean by sepsis?
To tell sepsis, we have to
Must. Huh? What is sepsis? Basically, you should understand what is sepsis.
Immune response to dysregulated immune response leading to organ dysfunction.
So organ dysfunction here, you think that LFT alteration is due to a multi-organ dysfunction? Yes or no? No. Then what is the main problem here? See, sepsis definition, you know that it is a bacteremia or toxins which is entering to the body and making all multi-organ dysfunction. But what is the difference between a sepsis in a normal person and a person is having very low immunity like neutropenia? How do you differentiate? What is the difference? All these definitions are for a normal person who is having good immunity. This patient does not have any immunity. Suppose you are infected with an organism, you have a high degree fever, hypertension, shock, everything will be there. But in a patient who is having very low immunity, neutropenia, so what will be the immune response? There will not be any immune response. So mild degree fever, hypothermia, everything can be sepsis in a patient who is having neutropenia. Even mild symptoms itself will show the patient is in sepsis. Okay, so we have to be double caution in this type of patients. What is the ulcer he is having?
Oral ulcer.
What ulcer? What type of ulcer it is?
It is a whitish plaque without any surrounding
So
inflammation or
what is the difference between
pain.
an ulcer in a normal immune patient, a person who is having neutropenic?
In a normal patient, there will be inflammatory reaction and painful.
Okay, so it will be a painful ulcer. Surrounding the ulcer, you can have inflammatory signs. But a patient who is having neutropenia, you don't see anything. Same like what we discussed. Patient may not have any symptoms, mild fever, mild symptoms. Like that, here also there will not be any major inflammatory signs.
So we started on strict neutropenic care.
That is strict neutropenic.
We have to keep the patient in reverse
Why
isolation.
is it reverse isolation?
So the patient should not get any infection from health work or hospital.
That is very important. So in a normal person who is having some infectious disease, we isolate the patient to prevent infection from that person to doctor or other patients. Here we are isolating the patient to prevent infection from our side to a patient.
And only one staff should
Barrier nets.
and patient
Barrier nets. One staff will not go anywhere. She will be sticking on, or that person will be sticking on to only that patient.
And hand washing should be done before and after patient care. And we started on and adequate hydration, and we started on injection meropenem since we have to cover broad spectrum.
What is the common organism which grow in a patient who is having neutropenia? What are the common organisms which can produce sepsis? Here you are telling sepsis. So what are the common organisms which can produce sepsis in a neutropenic patient?
Gram-positive
Streptococcus, Staphylococcus, MRSA.
Gram-negative Pseudomonas.
Klebsiella, Pseudomonas. Pseudomonas is the most dangerous organism in a patient who is having neutropenic sepsis.
Then,
What do you wanted? Nothing.
So we had to cover broad spectrum beta-lactam. So we have to cover gram-positive, gram-negative, and pseudomonal coverage. So we gave
What
broad
is
spectrum.
the pseudomonal coverage?
Meron.
Meron is a big antibiotic. What are the drugs come under anti-pseudomonal drugs?
Piperacillin,
Ceftazidime,
ceftazidime,
and
carbapenems.
carbapenems. Okay. So you have started meropenem. Okay.
Then we have
What
to,
else you want to cover? So meropenem is started to cover your pseudomonas. What
then
else?
antifungal was
How do you cover MRSA? Second major organism is MRSA. Vancomycin, linezolid, whatever it is, depending on the source of infection. We don't know the source of infection here, so we blindly start vancomycin, meropenem. Then third one you told.
antifungal.
Antifungal. Third one is antifungal. So these are the basic drugs we start from emergency room, but depending on the infection and the culture reports, we may de-escalate the treatment.
We can give antiviral cyclovir tablets.
Cyclovir is for what? What is the common virus which produces bone marrow suppression in a patient who is having parvovirus? What is the treatment for that? There is no major treatment. So parvovirus is the most common virus which produces bone marrow suppression in a patient who is on chronically on immunosuppression. So here why I am telling is methotrexate is a drug which can produce bone marrow suppression, but 30 milligram is not an adequate dose to produce bone marrow suppression because the normal dose we give in rheumatoid arthritis, we start with 25 milligram, slowly taper down. Okay. So 30 milligram is not a big dose in this type of patients.
And then we started with injection calcium leucovorin 10 to 15 mg every 6 hours.
Leucovorin is what?
It's will reverse the inhibitory effect of methotrexate.
Leucovorin is a brand name.
Folinic acid.
Folinic acid. Active form of folinic acid.
Folis catheterization was done to measure urine output because 90% of the methotrexate comes out through renal excretion. So urine output and adequate hydration should be maintained, and serial creatinine level should be measured to look for any renal function. And then injection GCSF 300 sub-Q was given.
What is GS?
Granulocyte colony stimulating factor.
Where all it can be used? Colony stimulation factors are useful in which
chemotherapy induced
It is mainly used in drug-induced bone marrow suppression. But nowadays we try to use in many other conditions where bone marrow suppression is there, but it is predominantly used in drug-induced bone marrow suppression. Okay.
Then we are sent further investigation. Since outside OTPT was saying we had sent LFT, but our total bilirubin, direct bilirubin, HGOT, SGPT came out normal. Creat was RFT, urea was 19.5, creatinine 0.61, and acute phase reactants like ferritin and procal was sent. Ferritin was 1563, procal was 183.
So do you think that this ferritin indicates inflammation here, or it's falsely not elevated? There is no inflammation to happen here because there is no neutrophil count. So the ferritin, even 1000 indicates a severe form of infection.
Total counts, lab values only 300, and neutrophils was around 40%. So absolute neutrophil count was 130.
130.
Then patient was shifted to MICU isolation under hematology. Further antibiotic treatment and further investigations and treatment was given over there and was discharged 5 days back. Counts was while discharging his total count was 18.6. Platelet, they had transfused 4 pint irradiated platelets was transfused, and his platelets on discharge was 1,12,000.
Okay. So how do you proceed with the treatment afterwards? Can we restart methotrexate or just leave it like that, or start some other molecule instead of methotrexate? We can restart. There is no issue. Methotrexate, if it is an overdose, cumulative dose, we can restart after once the patient is replaced. Or you can switch to some other tablet which may not affect bone marrow like this.
Methotrexate is an anti-metabolic agent with anti-inflammatory and immunosuppressive effect. It is an irreversible competitive antagonist of enzyme dihydrofolate reductase, which will pause the DNA synthesis. It also has single cell effect, which blocks the migration and proliferation of activated cells, so anti-inflammatory reaction. It can be administered orally, intravenously, intravascular, and subcutaneously.
Intrathecal. It's useful in intrathecal also. Nowadays we are not giving it. There are different types of drugs are available. So malignancy, CNS malignancy, and all it was used once.
Acute toxicity clinical features are sudden onset of acute toxicity is seen when there is increased free plasma levels. Usually 50% of methotrexate will be protein bound, but due to certain drug reactions, it can get displaced and active form increases in the bloodstream. Drug reactions usually happens with NSAIDs, aspirin, phenytoins, tetracyclines, or in patients with renal elevated creatinine renal disorders, elderly patient or pre-existing renal disease. Also, it can happen if patient was not adequately counseled about the drug dosage and when to take. Lack of re-emphasis on weekly dosage or patient having confusion regarding the dosage. Clinical features include acute sudden onset of mucosal ulceration, oral or genital, onset of fever, mucositis, esophagitis, acute renal failure, myelosuppression, diarrhea. Management involves folinic acid supplementation, maintaining urine output and adequate hydration, urinary alkalization, then monitoring serum creatinine and electrolytes levels. In folinic acid supplementation, leucovorin administration is done 10 to 15 mg of leucovorin given every 6 hours until the plasma methotrexate level is less than 0.05 to 0.1 micromoles.
So why bone marrow suppression happens here? Is there a reason for it?
Thymidylate synthesis, dihydrofolate reductase.
So it's a anti-folic drug. So because of the folic acid deficiency only you are developing all these things.
Long-term adverse effects of methotrexate are hepatotoxicity. Usually, it's seen in patients who are taking alcohol or have risk of liver, already having liver diseases like CLD. Pulmonary toxicity can lead to pulmonary fibrosis. Hematological side effects, myelosuppression. It is usually seen. It can be reduced by folic acid supplementation, but if patient is non-compliant, it can lead to myelosuppression. Cutaneous side effects like aphthous stomatitis, alopecia, hyperpigmentation can happen. Drug interactions like NSAID, phenytoin, tetracycline, and dapsone can happen. Other side effects are GI side effects, nausea, anorexia, vomiting, ulcerative stomatitis. Ulceration
Is
will
this
be
patient taking folic acid regularly?
was taking, but since last 1 month,
She has not taken folic acid. That
problem.
is the reason. Not because of the overdose of methotrexate.
Overdose because of pain. He had taken 3 consecutive.
That's okay. The 30 milligram normally will not produce bone marrow suppression if you are taking folic acid. She might not have taken folic acid regularly, and she is not having anemia.
No anemia, 11.5.
That is against parvovirus infection. Parvovirus normally produce complete bone marrow suppression, including patient can have anemia. Maybe folic acid is not taken properly. That is the reason. So we have to advise the patient whenever we are prescribing methotrexate, we have to counsel the patient regarding need of folic acid. Most of the patients miss folic acid. They take methotrexate.
Other side of GI side effects, reproductive effects like it is teratogen and abortifacient. Reversible oligospermia also can happen. Renal side effects is seen only in very high doses, 50 to 250 mg, due to precipitation of methotrexate in renal tubules. Then very rare side effects are osteoporosis and compression fractures of distal tibia.
Okay. Anything else? You want to add? Huh? Nothing. Okay. Thank you.